Hi everyone, my name is Jean Steenwijk, and today we'll talk about asthma management with a focus on the variety of medications we use in this disease state. Let's start with some background information on asthma. Asthma is a chronic inflammatory condition characterized by airway inflammation, airway obstruction, and bronchial hyperresponsiveness. It is one of the most common chronic diseases in children. In this figure on the right, you can see a normal airway in contrast to an airway during an asthma symptoms. There is excess mucus production causing mucus plugging. There is thickening of the airway in both the basement membrane and the smooth muscle, and there is also airway constriction. The etiology of asthma is multifactorial. Genetics account for about 60 to 80% of a person's susceptibility to developing asthma. But there are also many environmental risk factors, and these are the most important precipitant for a severe asthma exacerbation. In children, the most significant precipitant of severe asthma is viral respiratory tract infections. These include RSV, rhinovirus or the common cold, and influenza. Another theory for the development of asthma is the hygiene hypothesis. This proposes that genetically susceptible individuals develop allergies and asthma by allowing the allergic immunologic system, which are the T helper cell type 2, to develop instead of the system to fight infections to develop, which is the T helper cell type 1, and may explain the increase of asthma incidence in developed countries. Other environmental risk factors include exposure to secondhand smoke, allergen exposure such as pollen, dust mites, and animal dander, and air pollution. This figure demonstrates the complexity of the various factors that can cause asthma. As you can see, our common triggers like tobacco smoke, infection, exercise, allergens are all listed here. But I want to draw your attention to the blue boxes because these are the key drug targets that our medications for asthma utilize to reduce the bronchoconstriction and relieve our patient's symptoms. In addition to the triggers shown in the previous slide, there is also another cause of asthma called type 2 inflammation. This is a systemic allergic response known to play a role in the atopic triad, which includes asthma, allergic rhinitis, and atopic dermatitis. As many as 50 to 70% of asthma patients have a form of asthma that's characterized by this type 2 inflammation. And so this is something that you should keep in mind if a patient presents to you with moderate to severe asthma symptoms, because these patients can benefit from biologics that target the cells and pathways that link inflammation to asthma. And we will talk briefly on these biologics toward the end of the presentation. To diagnose a patient with asthma, we need to first ask them about their history of symptoms. Their symptoms should occur variably over time and also vary in intensity. And these symptoms usually occur after triggers. So ask your patients, are their symptoms usually triggered by exercise or laughter, any allergens, or maybe even cold air? And also if the symptoms appear or worsen with viral infections. These all point you toward the path of diagnosing a patient with asthma. But in addition to the symptom history, they need to also have confirmed variable expiratory airflow limitation with spirometry. So this can be documented excessive variability in lung function or documented expiratory airflow limitation. And so the things that we look for with the spirometry include the peak expiratory flow, which will be measured as the highest of 3 readings, as well as the forced expiratory volume in 1 second. The common symptoms of asthma include coughing, wheezing, chest tightness, and shortness of breath. Now let's move into treatment. The next few slides will go over the main pharmacological classes used for the treatment of asthma. The actual algorithm for treating asthma is covered in a separate PowerPoint. The first class we'll talk about is the inhaled corticosteroid, or ICS. These agents target airway hyperresponsiveness, inhibit the inflammatory cell migration and activation, and block the late-phase reaction to allergens. The inhaled corticosteroid class is the most effective long-term controller therapy for asthma patients. The onset of improvement is usually about a week. It is important for you to know that you should only use inhaled corticosteroids at the low or the medium dose, and really only reserve the high doses for severe asthma. And that is because corticosteroids are not without adverse effects. The most common adverse effect of inhaled corticosteroid is oral candidiasis, and this is why we tell patients that when they use inhalers with the inhaled corticosteroids, they should always rinse their mouth with water and spit it out afterward. Other adverse effects are hoarseness of voice, and it may slow bone growth in children. It's also important to recognize that there are some potential drug interactions with HIV medications containing ritonavir, which can lead to an increase in exposure to the corticosteroid in the body and leading to Cushing's syndrome. And so if your patient takes any HIV medication with ritonavir, you should prescribe them an ICS that has beclomethasone or fluocinolone. You should not use fluticasone, mometasone, or triamcinolone. Here is a table showing the various inhaled corticosteroid products and their dosing, separated in terms of low dose, medium dose, and high dose. It's important to note that this is not a dose equivalency table. In order to determine which inhaled corticosteroid you should select for your patient, it will really be largely dictated by your insurance plan as well as affordability. Next, we'll talk about short-acting beta agonists, or SABAs. These are also another workhorse for the treatment of asthma. SABAs are bronchodilators, selectively working on beta-2 receptors in the airway smooth muscles. It's important to note that these are only used as needed as the reliever inhaler, and regular use of these inhalers can indicate poor asthma control for the patient. The effect of these inhalers will last about 3 to 4 hours, and the adverse effects are typically mild, but if used very often, it could lead to tremor or tachycardia, or even in severe cases, electrolyte imbalances. The two main products are albuterol and levalbuterol. Levalbuterol is the R enantiomer of albuterol. It is twice as potent, so the dose is half of that of albuterol, but it is also more expensive. Most commonly, you'll see albuterol being dispensed as Ventolin or ProAir. The next class has a very similar name to the last class, and these are the long-acting beta agonists, or LABAs. So they also selectively agonize the beta-2 receptors, but they last longer, typically about 8 to 12 hours. The most important thing to know about LABAs in the treatment of asthma is that they should never be used as monotherapy for long-term treatment. And that is because LABAs can desensitize the beta-2 receptors, so that the emergency bronchodilation would not be effective. There is even a boxed warning for increased risk of asthma-related deaths with salmeterol and an increased risk of severe exacerbation with formoterol. So you will see LABAs being used in combination with the inhaled corticosteroid class for long-term control in step 3 therapy or higher in patients over 5 years old, or in step 4 therapy or higher in children aged 0 to 4 years old. In the new GINA 2019 and 2020 guidelines, they recommend using a low-dose inhaled corticosteroid Formoterol combination as needed as the reliever inhaler in mild asthma, which is in step 1 and step 2 therapy. Again, LABAs are the preferred adjunct to inhaled corticosteroid to improve lung function, decrease symptoms, and reduce exacerbations. Possible adverse effects include nasopharyngitis, upper respiratory tract infection, and headache. Here is a list of all of the inhaled corticosteroid and long-acting beta-agonist products. You may be familiar with these brand names such as Symbicort, Advair, Briolipta, and Dulera. For the new guideline recommendation, Symbicort was what was studied in the trials, but the Dulera is another option if patients were to use this as needed in mild asthma. Next, let's talk about the Leukotriene receptor antagonists. So what is Leukotriene? Leukotrienes can cause airway edema and smooth muscle contraction after allergen exposure. So when we block these receptors, it can counter the respiratory inflammation. These are alternative therapies at step 2, but they're not preferred over the long-acting beta agonists. The most common one is Singulair or Montelukast. This is given as a one-time oral tablet or even as chewable or oral granule packets. Once a day, usually given at night. It's important to know that earlier in 2020, the FDA added a box warning for the risk of serious neuropsychiatric events, including suicidality in adults and adolescents, and nightmares and behavioral problems in children. The other two agents in this class, Accolade and Zyflo, are less commonly used, and that is because they both have risk of hepatotoxicity. And if a patient was started on Zyflo, they must monitor liver function tests at baseline and very frequently afterward. Another class of agent that you may see in the treatment of asthma exacerbation is systemic corticosteroids. So these are used during acute exacerbation to speed the resolution and to prevent relapse. These can also be considered as an add-on in step 5. The oral route is preferred, but it takes at least 4 hours to see a clinical improvement. You could use IV steroids if the patient is too dyspneic to swallow, if the patient is vomiting, or if the patient requires intubation. The IM route may be appropriate at discharge if there's concern about your patient's adherence, but there's really no benefit of giving an IM steroid over PO. The typical dose for an exacerbation will be about 50 milligrams per day for 5 to 7 days in an adult, and about 40 milligrams per day or 1 to 2 milligrams per kilogram per day for 3 to 5 days in children. And there has been no benefit shown in tapering dose. On this slide, you can see the different potencies for corticosteroids. For example, compared to 5 milligrams of prednisone, dexamethasone has the same potency at only 0.75 milligrams, making it a highly potent corticosteroid. You also see that fludrocortisone has very little glucocorticoid potency, but a very high mineralocorticoid potency. Corticosteroid use is not without side effects. Here is a figure that depicts the suppression of the hypothalamus pituitary adrenal axis. What happens is when exogenous corticosteroid is given, the patient's body will have a negative feedback loop and causes lower release or even complete suppression of the body's natural corticosteroids. And this will lead to what is called a secondary adrenal insufficiency, with symptoms such as fatigue, nausea, vomiting, diarrhea, weight loss, hypoglycemia, and even depression and irritability. This is why we don't want to keep patients on corticosteroids for a long time, and when we stop, we must taper slowly. Now let's talk about some less commonly used agents in the treatment of asthma. The short-acting muscarinic antagonist, or SABA, works by inhibiting the muscarinic acetylcholine receptor and reduces the intrinsic vagal tone in the airways. The only agent in this class is ipratropium. You've probably seen it in the nebulizer Deoneb, which is a combination of ipratropium and albuterol. And that is because ipratropium should never be used alone for asthma, and it is only used in addition to albuterol in moderate to severe exacerbations in the ER setting only. Some possible adverse effects of this drug is headache, flushed skin, blurred vision, tachycardia, and palpitations. The counterpart to the short-acting muscarinic antagonists are the long-acting muscarinic antagonists. These are typically only used for COPD, except recently Spiriva respimat or tiotropium became indicated for long-term maintenance treatment of asthma for those over the age of 12. And they have similar adverse effects compared to the short-acting muscarinic antagonists. The Methylxanthines work by producing mild to moderate bronchodilation by blocking phosphodiesterase and increasing cyclic AMP. The two drugs in this class are theophylline, which is PO, and aminophylline, which is IV. This class is different because you have to monitor serum peak concentrations to maintain it between 5 to 15 micrograms per ml. And they also have a lot of side effects, including nausea, vomiting, headache, and tremor. So it's not very tolerable for the patients. Therefore, we rarely use this class of medication anymore for the treatment of asthma. And lastly, for patients with allergy-related asthma, asthma with eosinophil phenotype, or severe uncontrolled asthma, we do have some monoclonal antibody options. As you can see here, these are mostly subcutaneous injections with the exception of Symbicort, which is an IV infusion. The administration frequencies vary amongst the products. And I do want to point out there is a new class called a TSLP antagonist. And this drug's brand name is Tezspire. And this is indicated for severe uncontrolled asthma. These are all going to be prescribed by a pulmonologist or a specialist, but they're listed here just as an FYI. Now let's switch gears and talk about some GINA guideline updates. Before we jump into each step of the algorithm, I want to talk about a key change in last year's GINA guideline. Prior to 2019, patients with mild asthma only had to have a reliever inhaler like albuterol. Then last year, GINA came out with the statement that it no longer recommends treating adults or adolescents with asthma with short-acting bronchodilators alone. Instead, they should receive symptom-driven or a daily corticosteroid-containing inhaler to reduce the risk of severe exacerbations. Retrospective studies have shown increased risk of asthma exacerbations and asthma-related death with more canisters of short-acting beta agonists like albuterol that a patient fills. Use of 3 or more SABA canisters per year was associated with increased risk of asthma exacerbations, and use of 12 or more SABA canisters per year was associated with increased risk of asthma-related death. Now, it may not mean that this particular medication is dangerous for the patients. The problem is that patients who use their albuterol inhalers so frequently may not seek care from their healthcare provider to get on a controller inhaler. While the albuterol inhalers can provide some immediate relief, it is not the safest option in the long term. The aim of this change in recommendation is to reduce the probability of serious adverse outcomes at a population level. Here are some inhaled corticosteroid and long-acting beta agonist inhaler containing Formoterol. I would like to point out that Symbicort or budesonide Formoterol is the only ICS Formoterol recommended by the GINA guideline. There is another inhaled corticosteroid Formoterol product called LTRAS, and it contains mometasone, and this is available in the US market. However, the guidelines do not recommend it, likely due to a lack of studies using this drug. Before we get into the guidelines, let's talk about some general principles for treatment. The initial treatment for asthma should be based on the patient's symptom severity as well as frequency. There's a stepwise approach. So step 1 is your patients with the least severe symptoms or least frequent symptoms. So these patients only have symptoms less than twice a month and have no risk factors for exacerbations. If your patients have symptoms or if they need to use your reliever twice a month or more, they are considered step 2. Step 3 is when you start seeing nighttime awakenings due to asthma once a week or more. And then step 4 will be your very severely uncontrolled asthma patients. After you initiate the patient on a treatment for their asthma, you should always assess their asthma control in follow-up visits. So to assess control, you want to ask these questions. In the last 4 weeks, has the patient had any daytime asthma symptoms more than twice a week? Any nighttime awakening? Any reliever use more than twice a week? And then any activity limitations? If they said no to all, then they're well controlled. If they answer yes to 1 or 2 of these, then they are partly controlled. And if they say yes to 3 or 4 of these, they're uncontrolled. And these will kind of help guide your next steps. As I mentioned earlier, the new reliever recommendations were updated in the 2019 GINA guidelines. However, many providers still remain confused. So last year, GINA created 2 tracks to kind of clarify their recommendations. So first, let's talk about the first track, which includes the preferred recommendations. As you can see, the first track shows the preferred reliever inhaler is the low-dose inhaled corticosteroids and Formoterol. So the guideline recommends either Symbicort or budesonide Formoterol or betamethasone-formoterol, or Foster, this is not available in the US. Symbicort was the most well-studied combination of the two and was mainly studied at the dose of 160/4.5 micrograms. And just as an FYI from a medication access perspective, Symbicort recently became generic, which means that there is no manufacturer copay cards available anymore for this product. And that can make affording this medication a little challenging for our patients. So we discussed the preferred reliever, which is recommended in steps 1 through 5, and is the only therapy used in steps 1 and 2. Moving on to steps 3 through 5, we're introduced to a new term called MART, or Maintenance and Reliever Therapy. This refers to the use of the same components for reliever and maintenance. For example, in step 3, it is recommended to use a low-dose inhaled corticosteroid and formoterol daily and the same inhaler for a reliever when needed. It's important to note that the guideline recommends to only use the inhaled corticosteroid formoterol maintenance with an inhaled corticosteroid formoterol reliever. So that means that if you want to use a different inhaled corticosteroid and long-acting beta agonist or triple therapy, you should not use the ICS-Formoterol reliever, and instead the patient should be transitioned to a short-acting beta agonist reliever like albuterol. The use of the ICS-Formoterol inhaler as both maintenance and reliever therapy has been proven to reduce the risk of severe exacerbations when compared to the same dose or higher of other ICS-LABA combinations with an as-needed short-acting beta agonist reliever. And that is why the inhaled corticosteroid formoterol combination is the preferred controller and reliever therapy option in the newest guideline. So that was track 1. Now let's compare to the second track in the treatment algorithm. The second track shows the older recommendations that we are familiar with. So the reliever is the as-needed short-acting beta agonist, or albuterol. It's important to point out that using a SABA alone as needed is not recommended. You can see that in step 1, it is recommended for patients to take an inhaled corticosteroid in addition to their short-acting beta agonist. This is because studies have shown that short-acting beta agonist alone increases the risk of asthma exacerbations compared to an inhaled corticosteroid and short-acting beta agonist combination. So in track 2, when we look at step 2 and beyond, it is okay to use a short-acting beta agonist alone for reliever, as long as they're on a maintenance inhaled corticosteroid or a inhaled corticosteroid LABA inhaler. I want to point out that in step 5, you can move into triple therapy with an inhaled corticosteroid, long-acting beta agonist, and the long-acting muscarinic antagonist. So Etiology is a triple therapy inhaler, and the Etiology 100 microgram dose now has an FDA indication for asthma, whereas before it was only indicated in COPD patients. Here I want to point out that for the albuterol monotherapy reliever use, some patients may not be adherent to their maintenance inhaler, which has the inhaled corticosteroid, and they may only use their short-acting beta agonist reliever many times a day due to cost, lack of health literacy, and other reasons. These patients will be at the highest risk for exacerbations, and we should consider targeting these patients for a inhaled corticosteroid LABA reliever such as Symbicort for the maintenance and reliever therapy mentioned from track 1. We won't discuss in depth the treatment algorithm for children aged 6 to 11 years old, but just know that the GINA guidelines still prefer as needed short-acting beta agonists like albuterol for steps 1 through 5 for the pediatric population. The guideline does mention that you may consider a low-dose maintenance and reliever therapy for steps 2 through 5, but this is not preferred. Once initial treatment is started, it is important to revert back to the arrow circle of assess, adjust, and review response. If your patient does not have symptom control, remember to check factors beyond pharmacotherapy, such as comorbidities, inhaler technique, and etc. If your patient has maintained good control for at least 3 months, you can consider stepping down therapy. You want to make sure the patient is on board and that there are no travel plans or any respiratory infections during the step-down time. Your patient should always have a written asthma action plan, but it's even more important to provide clear instructions on the plan when stepping down therapy. Lastly, the guideline did provide some updates for COVID-19 and the asthma patient population. First and foremost, this is a population at high risk for COVID-19 related hospitalizations, so they really need to get vaccinated against COVID-19 and get boosted. The guideline recommends continuing to take their prescribed asthma medications, making sure your patients have a written asthma action plan and know how to follow it. They recommend avoiding nebulizers where possible, and also to avoid spirometry in patients with confirmed or suspected COVID. We have discussed a lot of different medication classes as well as products, so let's wrap up with some take-home points. Inhaled corticosteroids, or ICS, is first-line controller inhaler for maintenance therapy. As neither short-acting beta agonist or low-dose inhaled corticosteroid Formoterol can be used as a reliever inhaler. Leukotriene receptor antagonists are good for patients with allergies, but beware of side effects. Short course of oral steroids can be used for acute exacerbation. And new immunomodulators are options for difficult to treat asthma.